Okay, we're going to go ahead and get started. Welcome everyone to another day of the pandemic, science and society. Our first speaker today is Dr. Siobhan Wescott from the University of North Dakota and the Indians into Medicine program. She is going to be talking to us about the implications of the pandemic to Indian country. Welcome, Dr. Wescott.
Hi, everyone. I've been to St. Louis, and I tell you what, your weather is very schizophrenic. Like 1 minute it's a lovely day in the 70s, and the next minute it's an oppressive humidity and storms. So I feel for you guys, but it's also a wonderful opportunity. I'm so glad to be here to be able to share some perspective. And I want to make this also, I'm a physician, so there's some general information that I'm going to give that you might not get from anyone else, but it also pertains to what's happening in Indian country. So the title of this talk is Past, Present, and Future, because COVID is, influenza is technically an epidemic every year. And I have a feeling that COVID is going to be as well. Hopefully we can stay ahead of it once we get vaccines going, but this is the future. So I want to start with the 10,000-foot view. I'm an Athabascan Indian from Fairbanks, Alaska. This is outside of Anchorage. It's mudflats and Cook Inlet, just to get some perspective before we really get into the details. So I want to start, and I'm just going to ask you to consider, you don't have to put it in the chat or anything, but you probably know that there's a lot of lung tissue. We only have 2 lungs, but there's a lot packed in there. But you might not know exactly how much is packed in there. So there's a famous, don't Google it, there's a famous analogy of how much tissue, if you just put it out 1 cell layer thick, how much space that would be on a tennis court. So I have this little exercise. We're going to show some drone footage of a tennis court. And I want you to guess as you go. It doesn't go till the end. It's somewhere in here. It's not necessarily the last shot that is correct. So there's the size of your lungs. There's a person for perspective. So as you go pretty quickly here, we're not even at a quarter of a quart, and we already can barely see the lungs. That's about half a quart. Is that the answer? There's your full quart. And now we're going to go all the way out to 2 tennis courts. So I want you, again, think in your own mind, make your guesses. And I'll tell you the answer is 1 tennis court. And your lungs take up an entire tennis court. So just think about that. Those little pairs of lungs right here, an entire tennis court. So that's why, obviously we have to breathe. It brings in oxygen, it lets out CO2. So we can use up energy. We need that gas exchange. But a mask, tiny little mask right across your face, protects your entire tennis court of lung tissue. So that's why we say mask up. So that's the 10,000-foot view of why we have the recommendations to wear masks, and why that's important. Now the next 10,000-foot view I want to take, and I think this has already been shared with you. Is that correct? Not yet? Okay. So this is a fascinating graphic, and it shows the relative size of pandemics over history. So, of course, Black Death in the 1300s is the most dramatic, and we really don't have a good sense of what the actual numbers were. It's all guesses. Records back then weren't maybe as thorough as we would hope, as well as, centuries ago. So some of those have been destroyed, but we think, 30 to 50% of at least the European population died. The estimate is about 200 million people on the planet. So what's interesting is the next one, and this is from Forbes magazine, 56 million people died of smallpox. Of course, smallpox is absolutely a public health success of the nth degree because it's been eradicated. There are no naturally occurring cases of smallpox anymore, but in history, it's killed 56 million people. And if at some point you want to read the small print, it's too small. It killed approximately 90% of the indigenous people living in what is now the United States when there was contact with Europeans, because they had no immunity to the disease. So the Spanish flu is the next one, and actually this says 40 to 50 million. I've seen as high as 100 million. Records not so great from the early 1900s. However, that was also in the setting of World War I. So there was a lot. There was a lot of movement and chance for the infection to spread. So what's interesting, then there were subsequent plague infections, and if you're really curious about this issue, there's lots of debate as to whether the plague is actually just the plague, which is a bacterial infection, Yersinia pestis. It may have also been concurrent viral infections that were deadly. So it's hard to tell. Just a lot of people died in the Middle Ages. And then it goes down. What's really fascinating to me is HIV/AIDS is the next one up, and that is 25 to 35 million people. So we're getting ahead of that one now. At least it's manageable if people can afford their medications. So in the scheme of things, at the moment, COVID is way down here on the list. It still has impacted the lives of almost every person on the planet, but nonetheless, in the scale of pandemics, it's basically an asterisk. So just so we have some perspective, I think we're definitely up against a formidable enemy that we can't even see. However, we've survived worse. And sometimes very interesting things happen. So if you look at this largest plague, there's a lot of things that really killed the feudal system, where basically most of the people in Europe were indentured servants and didn't have a lot of opportunity. And when there were so many deaths, there were so many fewer workers. So anybody who was left alive afterwards had more opportunity, and it really paved the way for the Renaissance. So, it's a mixed bag. We don't want to see these deaths, but it certainly changes society. So, sorry. Oh, so there's the smallpox. So I want to talk a little bit about, I'm going to guess, and you can correct me if I'm wrong, that nobody has ever heard these next three words together. And they are a result of treaties between, at the time, the Department of War in the US government with Indian tribes in the US. And in exchange for their land, they retained certain rights, and they became domestic dependent nations. That is a legal term. And I see Martin has his hand raised. I'm not sure how we're doing this.
Yeah, I would just keep going. I'm taking questions in the question box, and we can get to them after, but thank you.
Sure. So what's fascinating, this is why it actually makes public health work a little bit more difficult, because tribes do not have to follow necessarily state laws. So most states have smoke-free workplaces, but Indian tribes are exempt. And so a lot of casinos run by Indian tribes are able to have smoking in some or all areas of the casino, which is not good for anyone. However, it's perceived that they make better profits if they allow smoking. So it's a real public health battle, but it's just one little example of the decision-making power that theoretically tribes have access to. In the case, I just wanted to bring it down to something personal before we talk about what's happening in COVID. So this is a picture of my mom, and she's holding a puppy. It wasn't in honor of International Dog Day, but there we go. So she was in a tiny village in Western Alaska called Crooked Creek. Her dad she had an older sister. Her mom was expecting, and her dad died in a fishing accident. And then it turned out that both her mother, who was pregnant, and her older sister got tuberculosis. So they had TB. And at the time, this is in the 40s, there was zero treatment. Well, I shouldn't say that. There was bad treatment. There was ineffective treatment. So really the only choice was to be sent to a sanatorium, which was over 1,000 miles away, to hope that you survive, but to keep you away from others. So at the time, and this is where, social policy and pandemics are really a mixed bag. The policy was that any orphan who was Alaska Native could not be cared for by other extended family members, which actually was our tradition. They had to be adopted out to white families in what we call the lower 48 or the continental US. So because her baby brother was born in a hospital in Anchorage, he was in fact adopted out, but my mother was able to be hidden by an aunt and stay within the family, even though that was very tricky at times. So, this is a long, complicated history, but that's only a generation from me. But the good news is that my mom went on to become one of the first women who are Alaska Native who earned a PhD, and she did so at Stanford University. And then I went on to Dartmouth College, and I got my medical degree at Harvard. So, there's hope when we survive these things, but you have to survive. So that brings us to our next point of talking specifically about how COVID is affecting Indian country. So this is a picture from April, and it's on a reservation in South Dakota called Cheyenne River. And they are in South Dakota, which has a very conservative governor who, for instance, there's a large hospital system based in Sioux Falls that did the first trials of hydroxychloroquine in spite of concern with the rest of the medical field about that drug, South Dakota. So the tribe did not want other South Dakotans or people from elsewhere coming onto the reservation. So they set up checkpoints, which theoretically they have the legal right to do as domestic dependent nations, even though it could be a federal or a state road. So immediately the state government threatened to sue and asked the federal government to intervene, and they have not done so at this point, which to me says that they couldn't find a legal basis to sue them because these are treaty rights, and that's the highest level of law in the US. So what's been really interesting, if anybody is biker, so Sturgis Bike Week was just broke up, and it's already spreading cases of COVID throughout the country. It was 250,000 bikers descended upon a tiny little town in western South Dakota, and now they're rolling COVID out all over. So I think this is going to be it's probably going to be similar to the Biogen conference, if you're really interested in this kind of thing. If you heard about this, that was, it's a pharmaceutical company, I believe, in Boston. And they had a conference early in the pandemic, and that is purported to have caused 20,000 cases of COVID that can be traced to people who attended that conference. So, you know, those are the attempts to control what's happening. It can get really contentious though, because just up the road in Pine Ridge, they shut down in a similar fashion as Cheyenne River. However, people disagree. You know, Pine Ridge especially is one of the poorest counties in the country, and not being able to have revenue by services was really upsetting. So actually the tribal board voted out the chairman for a period of 30 days because they disagreed. So this is really contentious. Everybody is struggling, but the best quote that I've seen is from the chairman of Cheyenne River, who said, so the nearest health facility is a 3-hour drive in Rapid City, South Dakota for critical care. And our health facility only has 8 beds. So if you look, the people that I can see is 4 of us. So if we each infected one person, then it's full. That's it. And there's only 1 respiratory therapist. So, and there's 10,000 people. So, you know, 10 times the number of people theoretically watching this talk right now, and there's only 8 beds. So if we were to have a massive outbreak, where are they going to go? So that was their rationale for continuing to have the checkpoints. So I want to talk a little bit. I'm not going to go into a lot of numbers because I tell you what, it gets very complicated, but part of those treaties is that healthcare was included. Now, in the mid 1800s, healthcare was like a cot and will amputate something if need be. It wasn't a whole lot more complicated than that. However, it was included specifically in these treaties, and it is the basis of the Indian Health Service, because at the time, the federal government was worried about continuous epidemics and wanted a legal right to quarantine Indians. That is in part why the Indian Health Service exists. I don't think any of those negotiators had a clue that in 2020 it would be nearly a $6 billion agency within the US. There you go. It's still underfunded. However, that it's all tied to epidemics. Unfortunately, for data purposes, but I think fortunately for the tribes, they have the ability to take over their own care from the Indian Health Service with what dollars were put aside for that tribe. So they can then keep their own data as well. So we don't necessarily have data of COVID cases that are occurring, either because the tribes don't have sufficient testing and or they don't have to share their data, so they aren't. The exception here is a bit of the Navajo Nation, which if it were its own state would be bigger than 4 states. The smallest 4 states combined. So it's quite a large area, and this is a picture of Canyon de Chelly in the heart of the Navajo Nation. But they're actually brought in for the first time ever. Doctors Without Borders has come to U.S. soil. Never been here. And again, it's because they're a domestic dependent nation. And I'm still waiting to see, I haven't looked at the Q&A if anybody had ever heard those 3 words together. Just curious. But that's, you know, that's how serious it is. And I don't necessarily trust the numbers because again, there isn't sufficient testing and not everyone is reporting, but it's amongst the highest death rates of any population that's been studied during this outbreak. And again, it's a rural setting. There's up to 1/3 of people living on the Navajo Nation who do not have access to running water. So this wash your hands business is not easy. Or when you have multiple layers of family in the same dwelling, it's really hard to protect the vulnerable, which I will also add, weirdly, is generally not the young. Almost always with infectious disease outbreaks, it's the very young and the very old that are most at risk, and anybody with pre-existing conditions or problems with their immune system in the middle are at higher risk. But this one really is geared far more towards the elderly. And then I suspect there's either something genetic, or there's one theory that if you've had your vaccines, that your immune system is a little bit, has an advantage. But we don't know why some previously healthy young people get sick and potentially die or need lung transplants because of COVID. We have no idea. So that's what's worse happening. And then just out August 19th, so just last week, the Center for Disease Control has an early release of some data from Indian country about COVID. And it's only in 23 states, because those are the states that are actually reporting by race, which is another issue. But we'll leave that to the side. Just say there's only so much data. And if you do read this, it's almost heartbreaking, but of course they say the data is complicated. It's complicated, but I took out the key point: 23 states with enough data on race ethnicity. The incidence where they've confirmed COVID-19 is 3.5 times higher than among non-Hispanic white persons. And the data has so many holes, they can't really make conclusions about beyond that, but just the sheer incidence is disturbing, 3.5 times higher. So we've talked some about the past, and really that epidemics are the reason that we have an Indian Health Service. We talked about the present, where tribes are trying very hard to keep COVID out, but it's a strain just for the rest of the country, because you can't have economic growth, or people's jobs are dependent on being able to stay open, and that's not safe. So I want to talk a little bit about the future, and I'm not going to go into a lot of detail about the structure of DNA. I just put it up for anyone there who loves this kind of thing. But I'm sure that you've all heard the term DNA, and it's basically just instructions. They're the genetics instructions that say what color your hair is going to be, your eyes, the shape of your face. All of that is written somewhere in that previous double helix. And the way that it works is that you start with DNA, then you go to RNA, and I didn't put it on the slide because it would be too busy, but DNA has a myriad of quality control. They care. It's like eggs. The inspectors are doing a lot of careful looking over and make sure that those eggs are good. RNA is like the farmer's market. There is not quality control. I mean, you can see if there was a problem that's really bad, yeah, but there's no way to know. And that's the way RNA is. So RNA is the second step. And then from RNA, you get protein production. And then after that, pretty much everything a cell does is done by proteins. So that's how important RNA is. But what's fascinating is that viruses, and this is a huge argument. Again, if you love this kind of stuff, I would look it up. If you ever need a debate topic, are viruses alive? So here's the deal. They are just a clump of either DNA or RNA surrounded by some envelope to protect them from the environment. That's it. They have none of the other machinery of cells, and they cannot replicate on their own. So they're like, what is it? A mule? Like they can't reproduce. It's the end of the line. They have to literally hijack some other cells, and there are even viruses for bacteria, but obviously we think mostly of the viruses that cause disease in humans or animals, and that is can either be DNA or RNA. Now, if it's a DNA virus, it's actually easier to control because there's better quality control in DNA, and so there are fewer strains that come about. RNA, not so much. Again, farmers market, lack of oversight. So we're going to do a little exercise here to show you just how hard it is to get quality control in RNA. And I bring this up because this is why we have yearly flu shots. The flu or influenza is an RNA virus. It mutates, and they see what happens in Australia because their winter is now. And then they pick the top strains and make a vaccine for the US. So that is an RNA virus, and coronavirus, which causes COVID-19, is an RNA virus. And it's already, to this point, again, I'm going to put a giant asterisk here because it's not certain, but it looks like they may have the first documented case of someone being infected by 2 different strains of the new coronavirus and got COVID-19 twice. We'll see if that's actually the case because it does seem like there's some immunity and antibodies. However, it's an RNA virus, so this exercise is going to show you just how hard it is. So I want you to take a clean piece of paper, or if you have an electronic way that you like to draw or take notes, go ahead and open up something blank. What I'm going to do, I'm going to give you 60 seconds to look at the next slide and try to start drawing it. So you can make as many squiggles and notes as you can. In the first 6 seconds, and I'm going to give you 4 more minutes to try and finish the drawing where you can't see the RNA anymore. So that is the exercise. Pull up my stopwatch. All right, so you're going to have 60 seconds when I hit the next slide. Go. I need to have some Jeopardy music going here. And we've recorded this exercise with medical students, and it was hysterical. There was one of them from Oklahoma who was like, you know, this looks like a 6th grader wrote it. All right, you're already at 30 seconds. So you have 30 more seconds to try and make as many notes and start in as many on the lines as you can to recreate this drawing. All right, now you have 15 more seconds. And if you're stressing, that is normal. 5, 4, 3, 2, 1. All right, so now you have 4 more minutes to try and finish that drawing. So I put up, this is our logo that I actually beaded. I don't recommend that. That was like, I'm surprised I have any eyesight left. But just something fun to put up. But you have now 3.5 more minutes.
Can I ask you a question while they're working on their memory exercise? So a lot of students have been asking, and I think that this is a common question within the US about the term Indian versus Native American and calling it Indian country. Who's allowed to use that term? Is that the term that we should all be using? Can you talk a little more about that? Because I think there's some, I think in the question, students are unsure of which terms they should be using.
Right, so that is a loaded question. And I actually am doing research on that very topic. So you'll understand as the students might not, when you submit a paper for peer review, you get reviews back, you don't know who wrote them. And I was on a paper, I was the only Native person, and it was trying to figure out what the average distance a rural Indian in the US had to go to see a dermatologist. So just physically where the building is versus where the Indians are. And we used American Indian because we couldn't include Alaska Natives because Alaska is so huge. It's 1/5 of the size of the US. So it would throw off all the numbers. So we specifically chose American Indian because that does not include Alaska Natives. And Native American does include them. So, and you have 2 more minutes. So there are legal definitions of what those are, and it's the Office of Management and Budget if you're really not sure which one to use, but that reviewer on that paper just assumed that none of us were Native and said clearly we had never worked for the Indian Health Service or with a largely Native population because we used the wrong term. And he recommended, or she, that the paper be rejected. So we changed some wording around and explained why we were using which terms we were using. And then the paper got accepted. It was for JAMA dermatology. And, you know, it turns out it's 68 miles is the average distance that an American Indian has to go to get to a dermatology clinic. So, and 1 more minute, by the way. So the conclusion is there's no right term, and if anybody tells you you should only use this term and not that term, they are incorrect. Indian country is maybe not the best saying, but it's actually the most prominent news source is called Indian country today. So it's kind of grandfathered in. And there isn't, yeah, I'm actually working on a very large research project to show the trends over time, and 30 seconds, guys, of how those terms have been used over time, because there's fascinating terms that I've never heard in my entire life, like Amerindian. So just one word, kind of like New Orleans, like just slurred it together, Amerindian. That's a thing. So, you know, I don't know what to tell you. I am actually trying to get, and we are done. So if you want to post your bad drawings, and I apologize for calling them that, but we all know that they're bad drawings, into the Q&A or the chat, that would be great. But you realize how hard that was. But I'd like for the major organizations that speak on behalf of the Native people in the US to come up with a new term, because all of the terms are terrible and people don't like them for a variety of reasons. And so one group will think it's the right term, somebody else will think it's not, and then you might not get funded or published. So yeah, that's the long answer to there's no right term.
Yeah, no, I appreciate that. Thank you.
So, and also just comment if you want on how hard that was, because it seems really simple. I mean, it's just 3 letters with some pattern in it, and it's not. So what I do normally, we don't have time today, then I have a separate DNA in different fabrics, and I let the participants look at that for 10 minutes the entire time, and they can try and redraw. So that really gives you a comparison. It's kind of, it's taking from the show Nailed It. That DNA does have some really great quality control, and RNA is just not. So that's why I think for the future, and that's why I put epidemics in Indian country, past, present, future. COVID is probably going to be around for many years to come. I think we'll be able to stay ahead of it once we get a vehicle for the vaccine that works. I do think that's also going to be very tricky. However, you know, there's just only so many things you can do.
Could you actually put back up the picture that they were trying to draw? Because the comments are coming in that it was very hard, impossible, much more difficult than they thought. They never realized how bad their memory was, and so on and so forth. So they just want to have a chance to look at it again. Yeah, I actually started, before I started talking to you, I drew, but I'm so bad at drawing anyway that I never thought mine was going to be good, and it's not.
Well, it's a very simple exercise just to show this is why RNA viruses are really a tricky enemy. Because just when you think you have a handle on it, because the original strain from Wuhan, China, is distinctly different from what spread in Europe, which eventually came here to the US. And now even within the US, it's mutating to the point where it's potentially able to reinfect people who had it previously. So, you know, we don't have enough information. I need to stress again, we don't know that you don't get immunity if you have it. There's not enough information, but I would suspect that it's going to be more like the flu, where we have to have a vaccine for it. And I'll have to I tell you guys, I have 2 Ivy League degrees, and now my ambition is to become a cat handler. So I'm gonna try and do. Here's where I am at this point in the pandemic. The internet loves cats. Vaccines, not so much. So I'm gonna try and make a video with my cat Tiger Lily, where in the first time you see her, she is the immune system. So we have defenses, and they can be quite ferocious, but they have to know what they're hunting. And in the first scene, she's just going to be sitting next to what looks like the coronavirus and ignoring it. And then I'll have something where there's a vaccine is available now and administered to the person. And then Tiger Lily is going to pounce on the coronavirus. Why not? Why not try to explain it? If somebody gets a vaccine just because they love cats and they think their immune system is a cat, I'm good with that. They don't need to know the science.
I think that is such a great reference to where we're at in this pandemic. Just with, you know, it's let's make some cat videos that might have a positive impact on the situation at this point. I'm for it. Okay, well, I don't want to interrupt your lecture, so if you had
no, we're done.
Okay, great, because the students have tons of questions that I would love to have the opportunity to ask you. One of the common themes of the questions is trying to get a better understanding of what life looks like right now in your community and the communities that you're talking about, in terms of, like, is it similar to what we're seeing in the rest of the United States, where children aren't going back to in-person school? Are there changes to cultural practices? What sort of, how is life different?
Life is very different. So I'll speak first to my existence, which for no apparent reason, I live in North Dakota. I'm not from here. I'm from Alaska. This is, my last slide here is Denali. It's the summit. I miss the mountains. There are no mountains here in North Dakota, especially where I live. It's just flat. But we have, as a university, the University of North Dakota went to remote working the 2nd or the 3rd week in March, and we just started coming back at the end of July. I still work exclusively from home. We brought students back. They are required to wear masks. We provide them with masks, but we already have had 38 students who are in athletic programs, because classes just started this week. Last week, 38 students already tested positive because they were in athletic training programs. So, or I guess it's possible, I mean, they came to campus early. So That's my personal existence. I think for Indian country, a lot of really wonderful cultural traditions were canceled this year. It's just not safe. So one of the ones in this area is called the Sundance, and it's a big festival. Uh, Canceled. Crow Fair in Montana canceled. People are not getting together more than their families. And even then, you know, the advice is to wear a mask, try and be outside the 6 feet. And that's hard. You know, you haven't seen a family member for months. You get to see them and then you can't give them a hug. I mean, it's just, or for those who, you know, if there's a new baby in the family and you can't hold that baby, to me, that's like a circle of hell.
Yeah, absolutely. So it sounds like in some ways the experience is similar, but
Very
then
similar.
there are also ways, I mean, including as you referenced the history and previous issues with outbreaks that kind of make it a bit different. And I think some of the students are really interested in understanding who makes the decisions. Like a lot of the students were not familiar with the term domestic dependent nation. No one said that they were familiar with it, at least. And so they're wondering, like, given that, who makes the decisions in those communities? We had a speaker talk about how it's important to have unified leadership, one leader that is making decisions and dealing with the crisis. Who is doing that?
Well, I think there isn't one answer because there are over 500 tribes in the US. So, you know, how those decisions get made, it's a combination of Indian Health Service and tribal government, but it's complicated. And that doesn't even include those, technically I'm an urban Indian. And there's an even more type called the suburban Indian. I'm not one of them, but you know, there's no tribe to protect them. So they are dealing with whatever decisions are made in whatever city or town they live in.
Yeah, okay, that makes sense. And you mentioned casinos. Students had questions about, are casinos contributing to COVID in areas where?
I don't think so. Actually, I think Las Vegas is worse. That seems to be another area besides COVID or Sturgis that's spreading virus. But no, they closed almost all the casinos in the country that were run by tribes closed. And I think they're slowly reopening with a lot of protections.
Mm-hmm. Yeah, okay, that makes sense. So I guess another question is about, because you work for the Indians into Medicine program, are there, in that program, do you see that the people in that program go into certain healthcare fields, or there's a particular type of interest given the history of outbreaks? Or is there an area that really within that program there needs to be more emphasis now that we've had this outbreak?
Well, North Dakota in general tends to graduate physicians who go into primary care. Family practices are our most popular choice of specialty, and we're very proud of that. So we are less likely to produce someone who is going to go into infectious disease. He's not native, but an exception is Paul Carson, who is an infectious disease physician now working at North Dakota State University, but he runs a Master of Public Health track in infectious disease, and I imagine it's quite popular this year. You know, we do need to adjust. We do need to switch focus, but that's not really been North Dakota's push. I will be interested to see what happens. In times of recession, generally education becomes more popular. It's a little bit like the Middle Ages. You know, there's some benefit to not having the status quo continue, and people's lives are shooken up, and they're like, what can I do? I need to improve myself. How about if I do that? And so you tend to see a spike in people pursuing educational opportunities.
That's great. Yeah. And students were also wondering, I mean, it seemed like early on for the Navajo Nation, for example, and other tribes, there was a recognition of this crisis and quick action to try and do something or to take safety precautions. And yet we've seen such a huge impact. I think you put up the number 3.5 times the infection rate of non-Hispanic white people in America. So do you know why? I mean, is it these underlying health disparities, or what, or is it the lack of support and healthcare? What's causing that number?
So I will say, when it comes to COVID, there are probably 68 questions for every answer that we have. So we don't know. Certainly, if the Indian Health Service were a person, you would categorize it as having significant pre-existing conditions. It gets chronically underfunded, 40 to 50% depending on who you ask. So, you just, there isn't the healthcare. Again, conditions where you have crowding, it's just harder to contain. There's also a lack of trust sometimes with state workers who are trying to do contact tracing, and they don't necessarily, people don't want to talk to them. It's not helping, but it's also understandable with some terrible things, like even in my own family, with what state workers did to the vulnerable, like my newborn uncle. So, I think there's a lot of reasons, and someday we'll sort it all out, but I do not have the answer.
Yeah, that makes complete sense.
And I'll tell you, so the director of research here at the University of North Dakota School of Medicine got sick with COVID. Fortunately, he was doing okay, but then he was really in a lot of pain. But he had heard that NSAIDs, like Advil, shouldn't be used in COVID, and so he was really suffering. And then one of his physician friends was like, dude, stop being an idiot. Here's the evidence. It's terrible. And he started taking the Advil and feels a lot better. So even physicians in positions of authority to make decisions are really struggling with the level of evidence here. It's just so much happening so quickly. So don't feel like the answers are there. Why can't I find them? Even professionals are struggling with this disease.
That's a really important point, and that's something that's come up over and over again in this class, the fact that the information keeps changing, because as we're learning, it's changing. And actually related to that, a lot of students have questions about the infographic that you shared with the different sized, and I didn't share that ahead of time with them because I knew you would be sharing it, but one question is, what date that was pulled from, because they were saying it seems like the number for COVID has changed since the infographic.
Yeah, so I think I pulled that in May or June. It's probably been updated. Again, I believe it was originally from a Forbes article. So I don't know, but there's a second graphic that goes with that shows over time. But I thought this one was more effective because it just is giving the scale of which ones are have most impacted all of humanity that we know of.
Yeah, no, I think that's good, and I think that's also a good point.
It's still a blip. It's destroyed our lives, but it's still just a blip when we look at the full force of pandemics that have hit humanity.
Yeah, and I do want to point out that was made by someone else, right? Because students were asking about, in this class, we've talked before about stigma around terms like Spanish flu and things like that, which that graphic used, but it's made by someone else.
And ironically, I think the Spanish flu started in Kansas or somewhere in the Midwest. So it was because the Spanish media was like, what is this? We're going to keep track of it. And that's why it's called the Spanish flu. It's
Yeah.
So yes, I apologize for that. I personally would not have chosen that term. I would have just said the 1918 influenza epidemic.
Yeah, exactly. Yeah, perfect. So along with that, students are curious because, of course, the COVID is just a minor point when it comes to the number of deaths, but there's all of these other things, like you were talking about how some people survive, so they might not show up on that infographic, but they have these serious health complications. So kind of wondering about how that works compared to other viruses that were in that infographic, as well as the fact that in these some of these previous outbreaks, we did not have the medical intervention that we have now. So maybe other ones would also have individuals that were infected and recovered or have lifelong issues from it or whatever. How does that compare when you look at those different outbreaks?
It's true. So I think in 1918, that was just about the time that they figured out how to give IV fluids, which anybody who knows anything about medicine, that is step one. You got to replace those fluids and electrolytes. And also that was just about the time that they finally figured out how to make it safe to give a blood transfusion. And I think that wasn't yet widespread. So that high death rate in part was because we didn't have the healthcare that we do now. COVID, I'll tell you what, is a completely new beast. It does not follow what we would expect. Like I've already mentioned, that the age groups that it is impacting is not what we expect. And it's also got what they're calling themselves the long haulers. So they're essentially, and this is a terrible term and I hate it. I hate it as much as Spanish flu, chronic fatigue syndrome. What does that mean? It has no definition. It's just sort of like, well, they said they're tired all the time, so they throw this term at them. But there's a group that are self-organizing long haulers who recovered from an acute respiratory illness and were COVID positive, but it's now 3, 4, 5 months later, and they are still feeling like they've been run over by a Mack truck. So whatever you call that, chronic fatigue, COVID long hauler, like they're starting to self-organize and have websites to track their symptoms and figure out what's going on, because it's new. This is not something we usually see. That's not the way respiratory infections usually work.
Yeah, yeah. Great. So also students were wondering, I'm completely forgetting the question that I was going to ask you. Oh my goodness, this is bad. Yes, I have it. They were wondering, as college students, university students, what can they be doing to help with the situation that you've described today?
Well, I think, first of all, they need to stay safe personally. So wear your mask, wash your hands, keep 6 feet apart, unless you're in close quarters. Don't touch your face like I just did, but this is why I stay inside and don't go to work. Because I joked early on in the pandemic that my penalty for touching my face was slapping myself, and that just defeated the whole purpose. But those are the simple things that you can do so that anybody that you come in contact with who might be more at risk will not get the disease from you. So I think if anybody wants to donate, there are a lot of great organizations that are taking donations. The Navajo Nation does have a fundraiser to help, especially for those who need water, because they have a whole system. Even though it sounds fair, like how can you not have running water? And I'll just indulge me for a second. I love the show Hoarders. It motivates me to clean up my place, which is already pretty clean, but so often you look and they have no running water, and it's terrifying and disgusting. It's not like that necessarily in Indian country. The Navajo have a whole setup for how they get water. And it's somebody drives a truck every day and there's a water truck in the back of it. And that is all that pickup does, is it gets the water. But with COVID, people are trying to stagger the times, and so there's fundraisers for that. If you want to be a part of that, I think that's a wonderful thing. You can always give to Doctors Without Borders, who's come to help out. I think there's a lot of ways, but generally, I think for everyone's sake, especially your own, just continue to practice what you need to do to keep from getting infected or spreading the infection.
That's wonderful. One of the students had said that they live in Arizona and that their mom works on a reservation, and that she has heard so much about these additional considerations, right, that really lead to hardships that we might not be realizing. I mean, thinking about the fact that somebody goes and gets the water every day, that's not something that everyone in the US right now or everyone on this call realizes is happening in some places. So I think that's really important.
It's very different. And like the 400 square foot cabin that I grew up in outside of Fairbanks, Alaska, we had running water because we had pipes, but we had a well. And so if the well went dry, you had to haul water. And that was just a part of life. That's what you did. So it's just a different mindset. But when it comes to controlling an epidemic, it's really more challenging.
Yeah, and students were interested also in your background and wondering, you know, what is it like to be a Native woman in healthcare?
Well, I'll tell you what, my favorite, I love to sell it. So I was often on call in third year with a tall white classmate. And he and I would watch in our matching Harvard Medical School white coats with our names on them, side by side, because we got paged. There was a patient, and a nurse would come running up to me, and this happened multiple times over many months. Like they never got the memo. They would come running up to me. Are you the translator?
Oh no.
And just like didn't even look at him. Didn't look at what I was wearing. That I had a stethoscope around it. Like, no. Are you the translator? And what was ironic is that Andrew, who was the tall white classmate, was fluent in Spanish and probably could have translated. So their stereotyping was not helping them. Yeah. But it's very difficult, and I could spend a long time talking about that. But I'll just put it that it's very difficult. And I do like to joke, though, for a while I worked for a large hospital system here in the Midwest, and I had to run cultural sensitivity training, which again, there's a whole circle of hell that could be trying to do that. But I would ask somebody to identify themselves. Do you consider yourself white? And somebody eventually would volunteer, and I would say, so what is the meaning of the square dance? I just want do-si-do at a hoedown, because that doesn't sound right. And so then I turn it around. It's like, when you come across a Native patient or a coworker who is Native, don't be all curious, like, what is a sun dance? It doesn't sound right. They put hooks in themselves. Like, so just ask them what their culture means to them. How can they be involved? Or if they want to learn more, what should they do? Don't come in with the most salacious thing and be like, tell me all about this.
That is an excellent message. We just have about one more minute. So one of the students wanted to know if you had to say what the one big takeaway is that you want students to get from this talk, what would it be?
We have survived worse. We will come out better because of this, but we have got to get on top of it. The US needs to pull its act together. Yeah,
that's a great final thought, and one that has been reiterated, I think, by a lot of our speakers. So thank you so much. This has been really wonderful, and I appreciate your time. Thank you.
I appreciate all of you. Thank you.
Thanks. Okay, have a good day. And we are going to switch gears now to our second speaker of the day, who I believe is here, but I'll just do a slow introduction to make sure that, yes, great. Okay, good. And So let me find my place here. Great. Okay, so our second speaker of the day is Dr. Patrick Fowler from Washington University Brown School. He will be talking about homelessness and evictions during the COVID pandemic. Welcome, Dr. Fowler.
Hi, everyone. I am pulling up my slides. I assume I can share my screen. Yeah. Okay. Let me get organized.
And just so you know, the questions will come in as you're speaking, but I'll be keeping track of them and then we can talk about them after.
Great. Thank you. Okay. Can everyone see this? Krista can see it, so I assume everyone can. Thank you, Krista. Thanks for having me, and thank you, Megan, for coordinating this. What I'm going to do is, today I'm going to talk about primarily local work that we've been doing in response to a serious crisis that we're facing, beginning to face, around homelessness and eviction post-pandemic. I have a handful of objectives for today. So basically, I'm gonna give an overview of homelessness as a public health problem, just to contextualize the conversation. I am going to talk about a unique situation where we've been working in St. Louis for 7 years and have developed a really strong community-based research partnership. And I'm going to talk about how we were able to pivot that ongoing research into a rapid response to COVID. So as I'm talking, my main take home is this idea of co-creating knowledge. This is the approach that our research takes, where we are blending both community science and data science in an iterative fashion. So we are engaging and re-engaging our community partners so that we can more rapidly get to better answers. It's not perfect, and this is a story that is full of small wins, big wins, and then some losses. So really what I'm going to do is describe the process. So Krista, I know that a major theme of this is disseminating information, using communication as a key tool. This is our communication tool that we're engaging in community-based research to get information used quickly. Okay, so some framing. If you haven't heard, we are about to experience a tidal wave of evictions. We're seeing this in all sorts of news reports, from New York to LA to DC to London to Singapore. We are, as a global community, worried about what's going to happen. What COVID has done is, and I'm sure you realize this, is that it has created an economic shock as well as a health crisis. We are experiencing historic rates of unemployment, which means people can't pay their rent. And it's a lot of people. Temporary relief through an eviction moratorium has already expired. So that was, it ended July 27th. There have been discussions federally to extend the moratorium. And in fact, we had an executive order that did not extend the moratorium, but did ask for what it would take to do that. Local communities, including here in St. Louis City, St. Louis County, St. Louis City and St. Louis County have initiated their own moratoriums, but communities are doing it differently. So for example, St. Louis City ends September 1st. So evictions will start again September 1st. St. Louis County is tying the eviction moratorium to how long it takes for courts to get back up and running using the state and national Supreme Court guidelines on readiness for reopening. So that is tied to our health recovery. Regardless, what matters is that low-income households are experiencing double jeopardy. They are the first hit by the economic shock, and they are the first hit by the COVID shock. COVID is occurring in the neighborhoods, same neighborhoods we're seeing high unemployment, high homelessness, high evictions. And just to make this point even more fine, this is a racial disparity issue. So plotting data that we can gather in the St. Louis region, it's very hard to see, but every red dot you see is a eviction filing even after the eviction moratorium. So landlords are filing for evictions, and they're filing them in big numbers. If you know the St. Louis area, these overlay with our underrepresented communities. So the green is the north side, which is primarily African American, as well as kind of along the river and the south side. So this is not only a public health problem, but a racial equity problem. Okay, so to contextualize this is kind of going back in time. This is our research, our ongoing research. So my colleagues and I have a global network where we're studying the prevalence of homelessness, the impact of homelessness, and how to prevent homelessness. This work spans multiple cities in the US, multiple cities in Canada, and around the world. I'm going to focus on St. Louis in the US now. What you're seeing here is our annual count of homeless persons going back from the time it started to our most recent numbers. What you can see is, if you look at the blue line, let's just look at everybody. We've had a somewhat of a dip in homelessness that is trending up more recently. This is bad. Any homelessness is bad because of what it means for families and communities. Our research shows significant deficits associated that exceed just general exposure to poverty and toxic stress, effects on academic achievement, cognitive development, behavioral development. Being homeless is just hard when you're a parent or a family member. It's hard not knowing where you're going to stay. And once you get started, it's hard to get out. Our work has looked seriously at how do we stop this? How do we stop this cycle? Federally, in the US, Canada, and some of our European partners, our biggest response is the homeless system. So the homeless system is a coordinated attempt among every community to identify homeless and to respond to it. And our major levers are, the one that we know the best is shelters. I'm on the streets, I need a place to stay, and you get a shelter. We also have dramatically expanded access to supportive housing, which includes long-term housing in the community with additional supports. And then, in fact, in the last economic recession, the Great Recession of 2007, we bolstered our rapid response to homelessness. A big component is prevention, providing time-limited assistance with rent, utilities, legal services that responds to an immediate need that keeps people housed before they need shelter or immediate place to stay. In what this figure is demonstrating is the complexity of this work. So I called it a homeless system, but really it's a complex network of local community-based agencies, advocates, and homeless consumers interacting with each other. So in St. Louis region, we have about 100 different agencies that are all responding and coordinating to support these multiple homeless system interventions. I just bring this up to say that it's a complex problem. When we think about major challenges in any complex problem, they align with homelessness. So homelessness, it's hard to predict. The causes of homelessness are multi-level and multi-determinant. They interact with each other. So getting a good sense of who will become homeless is a hard math problem to solve. And then when we can solve it, coordinating all these moving parts to rapidly respond becomes even harder. And this is in the context of scarcity. So we continually in homeless services have greater demand than supply. So nearly every community in the country is struggling with tight, affordable housing markets that is continually pressuring the homeless system. And the homeless system is given only a finite amount of resources to respond. And so what that creates is just continual decisions on who to help. Those decisions are not just a math problem to solve where to put resources, but also a moral problem to solve who to serve first, given that not everyone is going to get help. So just for example, if you show up at a shelter, it doesn't mean you get a shelter space in St. Louis. In at least one other community, New York City, it helps you get immediate housing, but in nearly all US cities, being homeless does not entitle you to help. So this is the context, skip this too. Oh no, I can't. Okay, so this is the context where we started our work. So like I said, we've been working in St. Louis really since 2012 when I arrived at WashU. And what we have been doing is kind of a long engagement strategy where we have deliberately partnered into the homeless system. So myself and my colleagues serve as consultants to the city and the county. We show up for meetings, and we've been doing this for a while. So we are part of the 100, WashU in fact is part of the 100 agencies responding to homelessness. And kind of where we started in 2013 was a problem of the providers and consumers of homeless services just didn't know where to go for help. And one of our first efforts was just sitting down with about 25 caseworkers in St. Louis and helping them map out the flow of resources. So this is a system dynamics diagram of how people could move through the system. And our community partners relabeled this the spaghetti map. This has become kind of a saying, continues to be a saying of if you want to describe the problem that our consumers are having with where to go for help, they refer to the spaghetti map. So that was our initial work. We continued that by engaging homeless consumers in mapping out solutions to the spaghetti problem. And these are pictures of community group meetings that we did where we asked homeless folks to help us understand the problems in the system. And if you can see, what we had them do is a structured activity where you plot out trends over time. And what we could do with that data is create an informal model of what's happening in the system. And consumers, just like our provider colleagues, identified this capacity and capability problem where there's just too much demand and people are continually being pulled off of frontline support to solve a crisis. And in that, they get in this trap of the homeless system is the capacities that it has get wasted and wasted and wasted. So this was a St. Louis dynamic that I think describes most communities, but this was built in St. Louis. And it led us to do some formal modeling of what to do about this. This plots a formal system dynamic model of the response to homelessness. So you have people who are in homeless services, which is in fact a small fraction of the homeless. A larger fraction are people waiting to get into services, and then especially people who are just doubling up with family, doubling up with friends, staying in encampments. So we built this model to test what do we do about this. I didn't know a good way to do this because I didn't share my slides, but if you use your phone, what you can link to is a website where you can run the simulation yourself. And it works by just kind of moving around different policy levers. And on the right, you can see in real time, you get answers of what to do about it. The big take home from our modeling was we need to ramp up this idea of homelessness prevention. So like I said, we had good evidence from the last recession that homelessness prevention was essential for solving that capability problem, the problem that the homeless system is always putting out fires. And so unfortunately, what happened after the last recession was essentially a federal defunding of prevention services. So despite showing really good effects during the recession, back in end of 2012, funding for prevention just stopped. So our work in as recently as this January was working with the city and the county to figure out how to devote more resources to prevention. And then the pandemic happened. It created, I'll frame it as a positive, a strength. It created opportunities. So our conversations in January about ramping up homelessness prevention were met with concerns that they just didn't have the money to do it. Part of the CARES Act, the economic stimulus to the COVID, included funds for prevention. So just like the last recession, this recession has expanded community capacity to try to keep people housed. And this is a great idea because it's hard to follow stay-at-home orders if you don't have a house or if you're staying temporarily in somebody's house. And you can only imagine the virus spread dynamics that emerge in encampments or in shelters. So pushing out dollars for homelessness prevention, which essentially, in a nutshell, it's providing time-limited rental assistance. So the CARES Act provided communities just money to help people pay their rent. And we liked that idea. The challenge was twofold, I guess. It was a federal lack of clarity on how the dollars could be spent. So there was no real mandate. It was, you can use this money for prevention, but it was not, you have to, or here's how much you should. Instead, it was, here's some money, you get to choose how to spend it. And so that's one level problem. The second level is the existing, what I keep saying is that the local response to homelessness has really just been investing in shelters and not kind of ignoring the prevention side of things. So come March, when we were faced with communities needing to make decisions about how they spend their CARES dollars, we started very actively working with the local boards making decisions about how to allocate COVID dollars. So this was work that I did with my colleague Jason Purnell at the now working for BJC, but continues to work in the Brown School, who has chaired the St. Louis Rapid Response team to COVID. And in this homelessness and eviction prevention, Jason had made it one of the priorities of that team. So with the RRT, the Rapid Response Team, we are able to get access to decision makers. So the rest of these slides are literally what I presented to the team. So this is part to explain the problem, but also show how we chose to respond. So it's a dissemination tool. So we framed this. So basically, these boards needed to, one, figure out how to spend the dollars that were directly provided for homeless services and homeless prevention. So roughly in the region that was, it's hard to track dollars, but let's say $10 million. But then there was two, dollars that could be spent on humanitarian components of the CARES response. So this is broadly much bigger dollars in the hundreds of millions that could be allocated for rental assistance, eviction prevention. So how we managed this big problem was to frame this as a three-part question. In planning terms, what we said is we need to get a sense of scope. So how big of a problem is this going to be locally? What is it going to mean for the homeless system? Because that's who the dollars are primarily going to go to. And what can we do about it? And more specifically, what can we do about it that considers both efficiency in terms of spending the money well and equity, which means addressing these racial disparities that we had already been seeing in evictions and we do see in homelessness. And so we framed it as three questions, and we use this inverted triangle to frame this for them. So you've got lots and lots and lots of families who are experiencing housing insecurity. Some of those will be due directly to COVID, which is what CARES dollars have to be spent on. And then some of those COVID displacements are going to be at greater risk for homelessness. So how do we target these resources as efficiently as possible? What we did was we translated that system dynamics model that I showed before that looked at national trends of homelessness under different policy contexts to a local context. So we recalibrated the structure. We collected more data on the local aspects of these dynamics to create some projections. Our goal was not to create a precise forecast model, but rather to get a sense of trends. What are we worried about? How big of a problem is this, and how long is it going to take to go back to normal? Like I said, we modeled this as a basic system dynamics simulation where we're tracking people moving into homelessness and moving out, given how much capacity we have to respond. And we looked at this monthly. So our time horizon is from after the eviction moratorium lifted, which was July 27th, moving forward. And we capped it, I think, at a 36-month period because projecting after that there's just too many unknowns. We built this on two primary groups of data. One was local information on poverty and homelessness and capacity to respond to homelessness. I am confident this is the best data that we have locally. It's not perfect. there are gaps, but it's as good as we could get. And then 2, we built it on evidence that had emerged around the importance of homelessness prevention. Given our prior work where we emphasized prevention, we thought that this is a good use of dollars. So we plugged in some of that into our modeling. And so to help folks understand the problem, what we did was just, we showed them the data. So I'll roll this out in a series of figures, but these are counts of homeless persons this is St. Louis County. I had to do this presentation a million times for St. Louis County, for St. Louis City, for St. Louis overall, but so this is St. Louis County. In St. Louis County, last year, between August to August, we would have we saw about 1,000 people who were being served in homeless services and about 8,000 served at imminent risk. So they were not in homeless services, but likely needed them. These are projections from our model that replicate the actual trends in the data. So we felt good about the calibration of the model. So we're valid. What does the model say moving forward? So what about 2020 to 2021, given a 6-month recovery and that includes a huge spike in evictions, and so a doubling of eviction filings from the prior year. We frame this as, what you see in the gray bars are the projected numbers moving forward. So in homeless services, not much of a difference. In imminent risk of homelessness, you're seeing a couple thousand additional households. 2 sobering points about this. The number in homeless services is not going to increase because our shelters are already at capacity. We knew this. We had encampments outside of City Hall at the time that people could not be placed because there's no capacity, and that's an all-year thing. The shelters are always over enrolled. The right-hand side seems optimistic. So 2,000, that doesn't seem that bad. That seems manageable. But this is a dynamic problem, and what it's not showing is what we see from the simulations is a long tail of recovery. So that 2,000 is only on this left-hand side of the curve. We're only expecting to see plateauing of homelessness, new homelessness due to COVID after 12 months. The real impact will be on the long tail to recovery. So we're not getting back to pre-pandemic numbers until well after 3 years, if we do nothing. What this means locally is that our homeless shelters will be even more inundated, but really we're just going to have people homeless in the community. And like I said, if we are concerned about virus spread, that's a really bad thing. And maybe I should describe this. So just to point out that the red line is what would have happened without a pandemic. The gray line is what we expect after the pandemic. So we made the case based on these numbers that we need to flatten the curve. We need to get in front of this housing crisis. And in our models, we ran the analyses. Even if we expanded shelter capacity, we're not going to be able to stop. We won't do a dent in this dynamic. What we think is going to do a dent is pushing out prevention dollars. So we are inherently making the case that the local response should prioritize prevention to respond to the eviction crisis. And we wanted to give some context based on the best data that we have, how good could we get and how much would it cost? The way that we did this was we, again, relied on our simulation models, but plugged in the best data available on the effectiveness of prevention. And the best data available comes from St. Louis. Work that we have done shows a really nice response to the last economic recession. It relies on this homelessness prevention, eviction prevention. I've already described this, but basically the way that it works is that it creates a capacity to identify housing crises early, match with time-limited supports that are maximally flexible. So if you're behind on your utility bill, which will get you evicted, you get that. If you're behind not on utilities but rent, you'll get that. If you need help just finding a place to stay, you'll get that. So it's very customizable. And the numbers are good. This is based on our research and then based on research done in New York and Chicago, where we've rigorously evaluated. What we see is a household level reduction in homelessness associated with prevention that's more than 25% reduction within a 2-year period. That's very large in social service delivery. But we also see an associated between 5 and 11% community-wide reduction in homelessness. So not only are we helping more people, we are flattening the homeless curve. And it comes with rigorous cost evaluations suggest we save a lot of money because shelter is super expensive and other homeless services are super expensive. One more point about St. Louis data is homelessness prevention is not only efficient, but it's also equitable. So we see that in Chicago, New York, that households facing greater economic marginalization do even better on average with homelessness prevention. So it's good if you're making no money. It's good. In St. Louis, what we see is prevention helped households that are at greatest risk of being discriminated in the low-income rental market. So these are African-American families primarily in St. Louis. These are families with children. Landlords, low-income landlords do not like children because they break things. And they do not like big families because they have more kids to break things. They also don't like adolescents. So if you're between 18 and 24, it's hard to find a landlord who will rent to you. And they don't like making accommodations, or they can't make accommodations given the housing stock in St. Louis. So what the data from the recession in St. Louis show is when we look carefully at this, we see this is plotting percent reductions associated with prevention. On average, we can everyone does well in prevention, but those who do even better include folks with chronic health conditions, folks with disabilities, families with children, youth aged 18 to 24. We didn't have all the data to test other likely subgroups that would benefit, like folks returning from institutions, incarceration, or mental health, or whatever. We'd likely expect a benefit from prevention because of their risk for being segregated. So we make the case that prevention is especially tailored for a COVID response because it's using the money efficiently, works, and equitably. So because these folks are decision makers, they're deciding how to use the money, we stepped into some, I would say, uncomfortable territory of projecting how much this would save and how many people would save. I say this uncomfortable because to do this well, we would need more time and more information. This is our best attempt. Some of this I really trust. Some of this is more for planning purposes and to elicit conversation about how to spend scarce resources. So the questions that we were asked were to what would happen if we invested in prevention? And so these decision makers really wanted to know, so if we only have 12 months to spend this money, if we are able to serve 4,200 households, how good of a job could we do? Given that prevention is good, but not perfect. And then what if we maximize the budget to 5,000 households over that 12 months? Just to put this in context, in the last recession, we served 6,000 households in prevention over a 2-year period. So this would be a significant investment, reinvestment in our prevention system. And we went back to our model and we created this counterfactual experiment. This is our fictitious world after the pandemic. This is our fictitious world if we were able to provide a prevention to 4,200 families. It's doing what we wanted. We wanted to flatten the curve. It's getting there. This is our fictitious world if we were able to expand to 5,000 households. This actually flattens the curve. This gets us back to pre-pandemic expected rates of homelessness. So this data is, I trust this data. If we can get this going in the way that we did in the last recession, this is suggesting that we can get ahead of the problem. We also framed this from an equity lens. We looked at who is most likely to benefit, and we pulled this data from the last recession of where prevention requests came from. And something that we see, at least this is St. Louis County, it works in the city too. These are the rank ordered neighborhoods that requested prevention assistance. Sorry, there's a fly. I think it's about to rain in St. Louis, just in case you wondered. For folks who know the county, what you know is that these are the neighborhoods that are disproportionately impoverished and disproportionately African American. At the time that we made these presentations, they also had the highest rates of COVID infection. And we calculated this in a different way, but in different ways, but basically making the case that the people who will get prevention are coming from the neighborhoods that need it the most, both economically and health-wise. Okay, so this part I don't trust as much. So we projected that we would save about $5 million in the first 2 years from avoiding homeless shelter stays or reducing homeless shelter stays based on the model. If you remember, COVID is not a homeless shelter problem, but shelter is expensive. So if you can prevent any shelter usage, you're going to get some benefit economically. So what the argument that we made was we are at least recovering the costs of prevention. And that's not accounting for the huge social costs and healthcare costs that you would likely see if we could quantify the vast majority of people being served in the community through prevention. This was our kind of take home, was just to invest in prevention and think flexibly how to do it. So we argued that St. Louis should prioritize dollars for eviction and homelessness prevention. we suggested that we need to recreate this targeting, this inverted triangle, so that we can quickly identify households. Given the data that we've done in St. Louis, we have some data-driven ways to do this that we thought would be good to use. And then this is also shaky ground, a projection of how much prevention would cost given our 4,200 households and 5,000 households, as well as where the money would get allocated. So what we were doing was giving our decision makers not only a general argument for prevention, but a specific argument of where to put the money. And what we said was put it in coordination of rental assistance. So most of the money, the top line, most of the money goes to identifying need quickly and providing rental assistance. Some of the money goes to eviction prevention. These are legal services for folks who have a procedural problem with eviction. Something that we've been tackling ever since these presentations is that legal assistance can help a lot of families, but it's not going to help without rental assistance. So once you make it to an eviction, you're behind on your rent. It happens, but the percent of eviction filings that can get thrown out of court are small, like real small, 10%. So the money, given it's a scarce resource, should go to rental assistance. And we've been advocating for broader eviction prevention by allocating additional dollars to utility assistance, to legal services. So long story short is we probably would, we need more money to do a good job with eviction prevention, but it's needs to be added on to the rental assistance dollars. And just to point out that this costs money. This costs, there is an administrative and an infrastructure fee. To do this well, you need data. You need a system that can collect information, can push out quick responses, can learn from itself, and that doesn't come without costs. We made some additional specific recommendations, and one of them is this flow chart where we advocated for local use of the United Way's 211, which is highly functional in St. Louis, especially around housing assistance. So 211 currently serves as our homeless front door, one of our homeless front doors. So it's already a telephonic support for that's known in the community for housing assistance. It also is our central social service connector. So it already has relationships with the not just the major, but the lots of community-based agencies that could deliver housing assistance. So this seems like an efficient use. Folks in the community have pushed back on this, saying we need more than just one phone number to get people into services, and in fact, subsequently, we created that capacity where folks can get homeless services through United Way, through the extensive network of community-based agencies, through their own applications, but all of that information is getting coordinated, or at least in theory, it's getting coordinated. So we felt good that capacity was created. And the rest of these rows just show what I've been talking about. It's homelessness prevention, and having a system that can field requests, manage referrals, and track outcomes. That's not important. That's not important. What's important is whether it worked. And what I can say is that, yeah, kind of. So we did, the St. Louis City and County both invested significantly in homeless assistance, and they did prioritize homelessness prevention. They did create the coordinated network on fielding requests for assistance. They have considered the challenges of long-term planning. The COVID CARES Act dollars are tricky. Some of them need to be spent by the end of the year. Some of them you get 2 years to spend, and there's still not enough money. So we've been pleased with the thinking around how do we do this. So let's spend the money that we have that needs to be spent quick first, and then let's focus on how to spend the rest of the dollars. There have been some really good progress. There's also been a lot of growing pains. The idea of how do we create a no wrong door capacity where folks can get assistance as quickly as possible from multiple sources, that became hard, and it became hard. It's a coordination problem, and it's a feelings problem. It became hard because people have skin in the game about who they want to work with, who they don't want to work with, and they have existing histories with different agencies, different coordinating centers, the city, the county. So there's been some heated debate on how to do this. We and other folks at WashU have continued to prioritize equity as a decision-making frame, and that has been heard, and that's good. I think what has become apparent is there's much agreement on making equity a priority, but how to do that is the details of how to do it have not been thought through carefully. So we've been pushing our partners to think about what equity actually looks like in this context, and how do you translate it into both a policy framework, but also a programmatic framework. That has caused some pushback on, we just don't have not enough money to do it. So we're still hoping to partner more with our communities on how to, at least for the long term, maybe not right now, but in the long term, how can we think about this, creating capacity for it? So the other challenge that we're not sure about is if it's going to be enough. And this is kind of the direction of our research now. Our projections are based on the past. So what's the average amount of assistance that folks need to avoid homelessness during the last recession? The current recession is not different yet, but could be. We could quickly see a collapse in the housing market. If the eviction moratorium continues too long, and if there's not some way to pay back landlords the rent owed, they will start to foreclose. They're a little more protected. They've got 12 months of protection. But what our simulations subsequently show is that there could be a bottoming out, and that causes problem. It also causes a programmatic problem where we're thinking that households are going to need about $3,000 or so in rent. If folks can't pay their rent for 6 months, those dollars are going to dry up quickly, more quickly. What we're working on, and then the last thing is, we also don't know how those bad actors are going to adapt. So when you make governmental assistance available in the community, the minority of landlords will scheme the system. And so we're also monitoring using data to look for that. So for example, we had a call last week about word on the street in St. Louis is that landlords are no longer evicting for rent in possession, which is not paying your rent. They are evicting for nuisance, or they're specifically evicting for drugs. They're saying you're evicted because we are concerned that there might be drug activity on your property. And so they're getting around the federally protected and the local protected eviction moratoriums by saying that low-income households are not getting evicted for financial reasons, but because they're a risk to our property. So that's word on the street, but we can actually track the data to look at those trends over time. And we're starting to think about how to do that in real time. Again, this is just this cycle of working with the community to find out what are the problems, what are the information needs, where can we insert ourselves, where should we not insert ourselves, and so it's this kind of iterative process that we've been going through, and we couldn't do it without some funding supports, as well as some great partners in WashU and around St. Louis and around the country and world. So I will stop there. I just talked too long, sorry.
That's okay. Maybe I'll just ask you a few questions. Students have a ton of questions on this topic. They're really interested in what you had to say, so thank you. But in the interest of time, maybe I'll just ask you a couple. One thing that students were asking about is this idea that you talked about at the beginning of eviction moratoriums, and trying to understand how that works a little better, like how that balances landlord needs with tenant needs, in addition to kind of what they've been hearing about in the news in terms of President Trump extending the money for these, or extending the eviction moratoriums. And then of course there seems to be this disagreement between the White House and Congress, or different parties, and how that's having an effect on what people are actually getting. Can you speak a little more to those issues?
Sure. Yeah, and it's hard to follow. So let me state it as a timeline. So in March, I think it was March 12th specifically, there was a federal decree that was processed through the Department of Housing and Urban Development that placed a moratorium on evictions. It applied to landlords who have Fannie Mae, Freddie Mac backed mortgages, which varies in communities, but we could say that it's about 90% of rental properties. It could be smaller than that, but it's a lot. That provided, I think, 120 days of the courts were not allowed to make judgments and execute evictions. So landlords could continue to file evictions, but the local courts could not act on those. When that moratorium was lifted, and it was lifted, it expired in July, communities around the country, including St. Louis, had a spike of evictions. But it wasn't that bad because most landlords didn't bother filing for eviction during the moratorium. Shortly after that moratorium, there was two announcements that happened at the same time. So there was an executive order that was framed as an extension of the eviction moratorium. That was not an actual eviction moratorium. That was what that did was allowed communities to continue planning and thinking about an eviction moratorium. There was no federal processing of that order. Regardless, communities like St. Louis City, St. Louis County, their courts applied eviction moratoriums, and many courts around the country have done the same thing. So we've extended. Is this a good idea? Yeah, it's a necessary component to responding to this crisis. Is it a long-term solution? No. As people are in the moratorium, they're not paying rent, which is going to cause landlords to lose income, and eventually they're not going to be able to pay their mortgages. A key component of the CARES Act was that these landlords could apply for 12 months of loan forbearance. So landlords had about 12 months grace period. Tenants had 120 days. So landlords are in a little bit better position, but that, like I said, is going to expire. So we're thinking about rent forgiveness as a policy option, what that would happen, where that would happen is not in the CARES Act that occurred in March, but in the next potential economic stimulus package. So we are waiting for those details. And so Congress is going back and forth about, how much money, how should it be spent? We don't know if there will be, an extension of the eviction moratorium, if there will be some component of rent forgiveness or landlord direct payments. We're not sure yet. And so that's the kind of back and forth.
That helps to clarify it a lot. Thank you. I think another question that students have more locally is the idea that, you mentioned like what's available has a big impact. So it's supply and demand, basically. And so they're wondering about the role WashU plays in terms of the fact that it buys some property. And then this year in particular, you have students that are juniors and seniors needing to get off-campus housing. How does that impact the situation in St. Louis specifically?
Yeah, so that's an interesting question, and Hank Weber would be the right person to ask that. I have not worked with WashU directly about this, but so here's kind of what I know and conjecture. So WashU has responded to making housing available, and I think in particular around international students. They've set up some protections that if we go into a second wave and international students are stranded and their countries won't let them back in, or they can't leave, the university is making housing available. And I think that's a good use of their resources. I don't know the dynamics of what it would mean to have rent forgiveness for students. I'm not sure if that's a good economic decision. I don't know if there are policies that would prohibit the university from making their properties available as maybe temporary housing. For example, an issue that we're planning on for the fall is what are we going to do when another outbreak occurs and people are entering homeless shelters with that are testing or having symptoms of COVID. Maybe the university campus housing could be used to house people as they wait their results, or maybe it could be used as longer-term housing. I don't know. I'm not involved in that level of decision making, but yeah. I do think that the university and the community are thinking about ways that everyone can help respond.
That's good. Good. Well, we are running out of time. I just want to ask you one last thing. A lot of students want to know what they could be doing aside from donating money. Is there something in particular? I mean, we have a large group of people paying attention to this class. What would you say that they could be doing to help this situation?
Yeah. So donate money. So the United Way, on their United Way's website, there is a portal for making financial and time commitments to local responses. It's part of the regional response teams of some of the work that they've been doing. There are things to do besides donate money. You can donate time. So I guess I would recommend people go towards the United Way website. If you can't find it, Google regional response team. for more specific opportunities to provide supports. And then advocate. So talk to your federal, especially your federal legislators about prioritizing eviction prevention. And the same could be done locally. Anyone in the city should send a letter to Lyda Cruson to keep encampments protected. So there are advocacy opportunities. Another resource is the St. Louis SLARCH, SLARCH, the St. Louis Regional Response to something. They're also provide information on advocacy advocates. So if you Google SLARCH, SLARCH, St. Louis homeless, you'll find it.
Okay, great. We'll put some of those resources on our Canvas site because I see students asking about them. So thank you so much for your time. I really appreciate it. Thank you for being here.
Yeah, thank you. Thanks all.
Yes.
Thanks for the questions.
Thank you. And to everyone else, I will see you tomorrow. Until then, stay safe.